Hysteroscopy, with dilatation of the cervix and endometrial curettage under general anaesthesia, has long been considered the method of choice for the investigation of abnormal bleeding and other diseases affecting the uterine cavity. With the introduction of smaller diameter scopes in the early 1990s, outpatient hysteroscopy became a more realistic option for both doctor and patient, with potential benefits including less anaesthetic risks, decreased costs, and increased patient choice. However, it is estimated that only 10% of American and British gynecologists and less than 1% of Australian gynecologists perform outpatient hysteroscopy. The reasons for the slow uptake of outpatient hysteroscopy are unclear, since studies show procedure success rates of 90 to 100% and patient satisfaction rates of 85 to 99%. We perform approximately 130 outpatient hysteroscopic procedures per year. Our success rate for the year 2005 was 93%, and insufficient samples for analysis were recorded in 14% of cases, mostly in postmenopausal women with a diagnosis of endometrial atrophy. This video illustrates the method of outpatient hysteroscopy as practiced in our unit. The procedure room should be large enough to comfortably accommodate the patient, doctor and nurse, as well as all the necessary equipment. Patient monitoring and emergency equipment is required for complications such as vasovagal episodes. The examination bed should be height adjustable with a retractable foot and should have comfortable foot stirrups. The hardware for outpatient hysteroscopy consists of the hysteroscope, camera, monitors. Ideally there should be two, one for the surgeon and another for the patient if she wishes to watch the procedure, a light source and lead, an image capture device, and a fluid giving set. We use a fluid distension medium, normal saline. This is delivered with an arthroscopy giving set which contains a hand pump. The hand pump increases fluid delivery as necessary and obviates the need for delivery of fluid under constant high pressures, as is the case with pressure bag delivery systems, which may cause more discomfort for the patient. The endoscope itself is a rigid hysteroscope. Hysteroscopy is generally performed with a 30 degrees continuous flow scope with a total external diameter of 4 to 5 millimeters. The combination of fluid inlet and outlet ports permit the clearest possible view. Anesthesia for outpatient hysteroscopy remains controversial. The cervix and uterus are richly innervated, with the cervix and lower uterus being supplied by mostly sacral parasympathetic fibres, and the uterine fundus supplied by sympathetic fibres from the ovarian plexus. A transitional zone of overlapping innervation lies in between. Discomfort during hysteroscopy is due to direct stimulation of nerve endings and prostaglandin release. Noxious stimuli producing pain during diagnostic hysteroscopy may include passing of vaginal speculum, clamping of the cervix, dilatation of the cervix, passage of the hysteroscope through the cervix, and distension of the uterus. Although the functional layer of the endometrium is not richly innervated with pain fibres, endometrial biopsy may cause significant discomfort due to stimulation of nerve fibres in the underlying endomyometrium. Tubal cannulation and disruption of the tubal mucosa during hysteroscopic sterilisation procedures also may stimulate pain fibres. Anaesthesia for outpatient hysteroscopy may include paracervical, intracervical or transcervical blocks, or application of topical preparations to the cervix, as well as simple oral analgesics. No particular regimen has been proven to be superior. Indeed, some practitioners routinely perform outpatient hysteroscopy without analgesia. Given the complex nerve innervation of the uterus, transcervical intrauterine installation of local anaesthetic has the theoretical advantage of being able to diminish the sensation of pain in the cervix, uterus and tubes, and without the pain associated with injection. The standard anaesthesia regimen for outpatient hysteroscopy in our unit includes prescription of non-steroidal inflammatory drugs the night before and 1 hour prior to the procedure, as well as intraoperative transcervical lignocaine. To minimise pain at outpatient hysteroscopy, gentle tissue handling and avoidance of unnecessary steps are essential. A speculum is inserted into the vagina to facilitate the transcervical block and is then removed. Instrumentation of the cervix with valsallam or tenaculum and dilatation of the cervix is not performed unless absolutely necessary, for example in the case of significant cervical stenosis. Instead, vaginoscopy is performed, where the hysteroscope is introduced directly into the vagina, and hand pumping of the distension medium separates the vaginal wall sufficiently to allow localization of the cervix and passage of the scope into the external os. Prior to vaginoscopy, the tip of the scope can be encircled with a gloved hand, which acts as a model uterine cavity to allow initial focusing of the instrument. The bevel of the hysteroscope is the presenting part of the scope. This corresponds to the notch on the monitor screen and is always located on the same side as the light lead. For introduction of the scope into the cervical canal, the light lead should be pointing downwards in the so-called neutral position. Importantly, to avoid loss of orientation, the camera itself should remain in the vertical position at all times and not be rotated. In the neutral position, the view from the hysteroscope is 30 degrees obliquely forward and upwards. This feature of the hysteroscope is essential for visualization of the entire uterine cavity, but can create difficulties negotiating the cervical canal if mechanical compensation for the angled view is not made. Hence the scope can only be advanced coaxially through the cervical canal if the screen image of the canal is located at the 6 o'clock position on the screen. In this video clip, the cervical canal is initially in the centre of the screen. The scope is advanced and a false passage is created. The operator then withdraws the scope, realigns the canal in the 6 o'clock position, and the scope can then be advanced into the uterine cavity. In this clip, gentle pressure supplied by the hand pump opens up the cervical canal and the mucus trail can be followed into the uterine cavity. The scope is advanced to the uterine fundus and refocused. In contrast to the small vertical and horizontal movements used to negotiate the cervical canal, inspection of the uterine cavity is made primarily by rotational movements of the scope. To view the left cornu and tubal ostium, the light lead is rotated 90 degrees to the left, as is the notch on the screen. The light lead is rotated 90 degrees to the right to view the right ostium. These are the cardinal movements of hysteroscopy and allow the entire uterine cavity to be visualized. The scope is then slowly withdrawn to obtain a panoramic view of the entire cavity. Endometrial biopsy with a suction device such as a Papel or other operative procedures may now be performed. It is beyond the scope of this presentation to describe the operative procedures performed at outpatient hysteroscopy in our unit in detail. With adequate training and experience, hysteroscopy may be performed successfully and efficiently in the outpatient setting. We believe that this technique should be routinely taught to gynecologists in training. Subsequent freeing up of valuable theatre time, as well as significant savings in healthcare expenditure, can only benefit an already overstretched public hospital system in Australia.